Hi, I'm Ashley Murphy, and I'm going to be talking about chronic pain and feminist integration. So chronic pain is a worldwide issue and affects approximately 1/3 of the United States population. We know pain is a normal sensation that alerts us to possible injury, and it becomes chronic when it continues past 3 months. However, it's a lot more complicated than that. Treating chronic pain includes the multiple diversity layers that an individual may hold. Women and marginalized individuals have been discounted for their pain experiences, resulting in misdiagnosed symptoms, increased pain and daily impairment, and leading to distrust in healthcare professionals. This review of literature will incorporate how a feminist framework can be integrated to facilitate and strengthen chronic pain interventions and interactions among healthcare professionals and their patients. So the research shows that women's experiences are considered invalid. They may be seen as hypochondriacs, weaker, less rational, more emotional, and more likely to complain than men. In addition, there's ideologies that underpin beliefs around, Black individuals do not feel pain at the same intensity as whites. They also say that Black women are exceptionally strong and accustomed to suffering, regardless of class. And also, Black individuals feel less pain because they have faced more hardship. All of this can lead to, the symptoms being misdiagnosed, thus delaying appropriate treatment, which also means there may be pain that is less aggressively treated. But this can also lead to increased pain impairment. And then all of this can lead to more distrust and ambivalent dependencies on healthcare professionals. So we know there's some socioeconomic impacts, such as power dynamics in the hierarchical medical system. There's the Western medicine and contemporary medical model of illness and disability, which values the objectivity and generalizability. Subjective knowledge may be seen as personal, not universal, and disability is seen as a problem to be fixed or cured. We also see gendered illnesses, such as associated with stereotypical traits associated with women, pathologized poverty. This includes applying for disability, and also some individuals are seen as welfare queens. And then it is also shown that there's some professionals out there that are more interested in health-related outcomes. So for feminist integration, there's two models. There's the participatory action research, and they emphasize self-examination among oppressed communities, empowerment of those involved, including the community. They encourage action, encouraging egalitarian discourse between any researcher and participants, but most importantly, they see the participants as the experts. Next is the feminist ecological model, and this model highlights voices of women, putting their voices in the center of treatment. It helps you listen, integrate, and honor experiences within an individual. It considers psychosocial interactions. It facilitates changes, not just for the individual, but the system as a whole. Understands the multiple layers of influence, and most importantly, it encourages inclusion of identities. And overall, if we look at the biopsychosocial conceptions of disability and feminist therapy, they're congruent. They both emphasize the social and attitudinal environments as highly impactful components of the disability experience. And we also know that medical professionals need to recognize and address problems within their own health system, including understanding the meaning of power and gender and the negotiation of systems and supports. So where is research currently at? Well, CBT is the standard intervention, and it modifies beliefs about pain, and it's more effective when integrated into a treatment plan. We also see that we're moving towards a more integrated mind-body approach in treatment, which includes roles of behavior, mental health concerns, and healthcare costs. There's the biopsychosocial model, which integrates person-environment approach and is the most preferred in conceptualizing the nature of health conditions. We're looking at relationships between illness severity and well-being, which may be explained by the individual in perception of their functioning in life roles. This includes how race shapes the moral boundary work performed by women suffering from disabling chronic pain. And then lastly, navigating the moral community, as there's currently a mindset of there's worthy and disabled versus malingerers and disability frauds within the social imagination. So what do you need to take away from this? Well, it's very important to 1, address psychosocial distress, 2, look at the autonomy, interpersonal relationships, and 3, identity management, including positive self-re-identification, which incorporates chronic discomfort into identity.